feeling you get when you're a novice and you are asked to go see a patient in the ER, admit them, work them up, and then staff it with your attending, and you have no idea what you're doing and you just want to die, and you think, okay, all right, think smart things, use smart words, make smart decisions, don't do dumb stuff. And you go, you meet with your attending, you staff the patient, you tell them your assessment and plan, and dumb stuff just comes out and you just want the ground to swallow you up. Everybody goes through this. It's completely normal for everyone, whether you're an NP, PA, doctor. Everybody's been through this phase where they had to speak to someone much smarter than them about their plan and dumb stuff comes out. It's an awful feeling, and it just takes time and it gets better, but I'm going to give you some tricks in this video about how to go about using your smart words and making your smart decisions so you don't look dumb. If we haven't met yet, my name is Bree. I'm a nurse practitioner. I work in an acute care setting. If we haven't met yet, welcome. Glad to see you. First things first, what does staff mean? Well, it's an old term that just means you are going to go present your patient to your attending physician. This is going to vary a little bit based on whether or not you're doing like daily rounds with a progress note versus an admission versus a consult. It's also going to vary a little bit based on whether or not you have experience or not, as well as your experience with this physician. So as a quote-unquote mid-level, you have to kind of swing a lot of different directions based on who you're working with. This is how you're going to set yourself up for success, is just altering your style and your technique just a little bit based on who you're working with, because medicine is still an art. And while there are guidelines and there are general ways in which we all practice, everybody varies a little. And once you get to know your attendings and their preferences, it becomes much easier. So in this video, I'm going to give you an example of an ER brand new admit that we don't know much information about. Okay, so you have been asked to go to the ED and admit Mr. Joe Blow, who's 78 years old. And let me just take a minute and say, I definitely am feeling my high school vibes. Like maybe I could be a high school geometry teacher. You remember when she had the microfiche that she would put up and go through all the problems on? That's kind of what I'm feeling like right now, because I'm going to cover up some information and display it later, just like a teacher would. Okay, and there's a reason for that. All right, so when I work up a patient, it is probably not the way you've been taught in school or possibly even by your other preceptors. But this is how I do it. This is real world. This is what I teach all my students. Okay, because I'm a critical care nurse practitioner, most often the patients that I'm seeing are intubated or confused. They are terrible historians. They're not able to give me much of the story. So my HPI is going to come from my families that I'm going to call, because we're in COVID era, there are no families there, and the ED staff. So because I want to call the families at the end and I want to be able to give them some information, they're scared, they're going to want to know things, I want to have some general feel about what my plan already is. So the first thing I do is breeze by the room in the ER and make sure everything's stable. Is the patient stable? Are the hemodynamics stable? Okay, and then I look at a brief, little glimpse at the monitor, and then I breeze over to my computer. And I will start going through all my labs and diagnostics before I read any notes. Now, I've probably already been told by my attending that this patient is here for respiratory failure, say, but generally that's all they're going to give you. 78-year-old in the ED, intubated, respiratory failure. That's all you're going to get. Room A1, that's it. So you're not going to have a lot to go on. To start with, at least. So I go through, before I read anything else or talk to anyone else, I want unbiased information. So I go through and write down all my pertinent labs, and I will highlight things that are abnormal. And as they're abnormal, I will start making a problem list. I can't do that yet. Okay. Anyways, so I would be writing down hyperglycemia, AKI, leukocytosis. I'll be working at my problems already, and you're doing this very, very rapidly. My papers often don't look this neat either, but this is just for the sake of illustration here. So write down all your pertinent labs. I often will check my INR and troponins. I don't usually write these numbers down, I just kind of memorize them. And just start highlighting the pertinent things. Now this person's here for respiratory failure, so my gas is going to be really important. And these are the only numbers on a gas I want to know. Those three. Don't care about the others. The bicarb is going to be calculated on an ABG, so you have to look at the CNP for that. So these are the things that I write down. He's got a fever, he's hypoxic, just on 15, well, he's on 15. Okay, in my example, this patient is not yet intubated, but he's confused and can't give you history. Okay, he's not yet intubated. That's not what your attending told you. Your attending just told you he was short of breath. All right, then I'll go through and look at my radiology and start writing down that information. I've got a CT of the brain, which tells me, I don't know, maybe he was confused or there was some focal deficits and that's why they got it. My x-ray, he has diffuse ground glass opacities. He's got a consolidation in the base. I always look at an echo. This is one from 2019. This is often how it's going to be. You may not have one currently, but you look back at the previous one, and I check my EKG and anything else that might be there already. But you know, you're in the ER, so workup is still pending. Then I'm going to start doing all my other tasks. So other categories that I think have pertinent information is your microbiology, what cultures have been sent thus far, including your UA. COVID's been sent and it's pending. ID, this is where I write down if they've had a fever and what antibiotics they're on and what day they started on. Obviously, he's not had any yet. In my IO section, I usually will write down the cumulative. The C is supposed to be for cumulative, so what their net cumulative volume is, whether it's positive or negative. And I have a side tangent about that because I often do not believe documented I's and O's because I've worked as a bedside nurse and those numbers are almost always off for some reason or another. So I really like weight. This patient has been here, but if it was an established patient, I would get my 24-hour balance as well. And then this is where I'll put my part of the exam about whether or not I think they're volume overloaded or not. And then I will go in the room and talk to the staff, talk to the patient, see if he's able to give me anything. So what you get is this history from a previous note, because the patient's confused and can't really tell you much. I will call the family later and confirm all of these things because you can't just copy things forward. That's how errors happen. Everybody's been charting he's diabetic for 20 years and he's not really. And then he may be able to tell me some of this, but a lot of this I'm going to get from the family when I call later. You know, he's had a history, 3-day history of productive cough, dyspnea, malaise, fever, blah, blah, blah. You can read all that. And he's mildly confused. Then I start my problem list, okay? Okay, I'm just going to take that off. So this is my workup that I've already started. My primary problem being first, that's my acute hypoxic respiratory failure. I think his history is definitely significant of COVID, especially in today's day and age. And I suspect that he may have a lobar pneumonia, community-acquired pneumonia, because he has this consolidation on his x-ray as well as a white count. Those are not things that we typically see with COVID, so he may have both, which is something we commonly see. And my big, question here is whether or not he wants to be intubated because he's already on 15 liters. He's confused. He's got a productive cough. He's also a little bit hypercarbic. So is he awake enough to protect his airway and cough up all the sputum? Because the next step here is going to be OptiFlow, something that is going to give you a higher amount of FiO2 and support. And that's ideal because it doesn't cover the mouth. Once you put him on CPAP, BiPAP, that would be the next tier up. But the problem with that is all of these things, confusion, possibly inability to protect airway, cough up secretions, and is he going to then aspirate? Because they cough into the mask, there's a lot of positive pressure and it goes into the lungs. So that's something I'm going to talk to my attending about when I staff it. Here's where I put down my pertinent labs for my COVID. These people rarely have COVID tests pending unless they went outpatient. So I look up some of the markers to tell me if the markers are indicating COVID, which they are here. He has an AKI. That's pretty generic. You know, in this case, I think this guy's a little bit dry based on this. His creatinine's up. He's also, you know, got 3 days history of this, and with the confusion, these folks are often not taking in any volume. So part of my plan is going to be to give him a little bit of fluids. Hyperglycemia, altered mental status, which is probably related to the infection, plus the uremia, plus the hypoxia, plus or minus hypercarbia. Lots of reasons. But there are other things in the workup I'm going to need to include. So then I start going over here and putting in orders as I'm down there. I'm going to check procalcitonin to confirm my cap, or at least just give me more information about it. I'm going to add them on cap coverage. I'm going to add him on these things for the COVID, the Decatron, vitamin C. I'm going to follow his markers. And the big question is, what are we going to do for his airway? Sputum culture, fluids, renal panel, echo, code. Okay, then I'm going to call the family. And where I work, I have a ton of autonomy. I work in a wonderful facility. I'm going to go ahead and call my family, confirm my history, confirm the chief complaint, get to know his general baseline functional status, which tells me how he may do with this, and tell them what I'm seeing, what the plan is. He's going to come to the unit and what they can anticipate, a little bit of what the prognosis may be, although you're going to be kind of vague on that because it's early. Then I'm going to go upstairs and talk to my attending. And I will change this view to where you can see my face, and I will give you my brief presentation that I would give to my attending with my plan. Okay, so you've seen your patient, your workup's all done. Now it's time for you to give your presentation to your doctor. It's going to be fine. Just take a deep breath. It'll be totally fine. You're going to get better with this with the time and experience, so it does get significantly easier. And when you're new and you don't know this person, probably more information is better than less. However, in general, I would like to say, I don't care what personality your doctor has. There is no doctor in the world who wants to hear you ramble for 20 minutes. You are going to lose your audience. So keep your audience in mind when you're speaking to them. Some people present in an SBAR format where you start with a situation, you give the background, the assessment, the recommendations. You can do that way. The take home here is that you want to give the big picture, what they came in for, what their current problems are, what your plan is, and where they're going from here. Concise is best. So let me present to you the patient that we just worked up that I would give with an attending that I am familiar with already. 2 keys I want to point out before we get started here. Focus on your pertinence, okay? Don't give them all the extraneous information. Hone in on what you think the most likely diagnosis is and give them only the pertinent information to that. And then you can sprinkle in some of the other acute problems that you're going to address. But what they really want to know is, what's the big problem? And give the diagnosis at the start so that they can then receive all that information with that filter in mind. And it's easier for them to process all the data you're throwing at them. Make it easier for them, okay? All right, so here we go. I went to the ED to see Mr. Joe Blow, who's 78 years old. He is here with acute hypoxemic plus or minus hypercarbic respiratory failure, which is likely COVID plus, I think, a community-acquired versus aspiration pneumonia. He's sort of a debilitated older man. He's got a lot of history, COPD, OSA. He's obese. He has diabetes, hypertension, heart failure, all the things. And he was confused. He really couldn't give me any history, and the family tells me this is off from his baseline. So he was on 15 liters nasal cannula. He was only satin like 89%. He was tachypnic. His workup breathing was moderate, but it was not awful. His PO2 on his ABG was 60. His PCO2 was 49. He's just a little bit acidotic with that at 733. He's currently awake and protecting his airway, but he's got a productive cough, which is concerning to me for BiPAP usage. I asked them to start him on an OptiFlow at 100% and see if we can get the oxygenation up, and maybe with a little bit of that positive pressure, it'll be just enough that we can avoid the BiPAP, because I don't think he'll do very well with it. I've started him on cap coverage, empiric, azith, and Rocephin. I don't think he needs HCAP. He's not been on antibiotics. I don't think he needs all of that. He also has a little bit of an AKI. Family tells me he's not been eating or drinking in several days. He looks dry. Now, he does have heart failure. His EF is like 40-45%, so I'm just going to give him some gentle diuresis. I'm going to give him 500 of LR and see how he responds to that. He has an old, the echo is old from 2019, so I was going to repeat that because his blood pressure is a little bit soft at 94/62. He's hyperglycemic, so I'm going to give him a sliding scale, especially since I'm going to start Decadron for the COVID. That's going to drive up his sugars. And he's altered, which is likely from the uremia, plus the infection, plus the hypoxia, all of these things. I don't think we need to do any further neurological workup. He did have a CT of his brain that was negative. As far as the mentation goes, this is also a concern for me with the BiPAP. He would probably require Precedex because he's going to take the mask off. And with the productive cough, all of these things, I don't know how well he'll do on BiPAP. So I talked to the family. He has a living will that says he is for intubation. They want all the things done because he's a fighter. So I think we just need to watch him really closely. We need to bring him to the ICU, put him on the OptiFlow. I'll check a gas later on, NPO for now, and just watch him really closely. His x-ray is pretty convincing. He's got ground glass opacities. He's got, I think, right lower lobe density, plus a leukocytosis. So he's probably got bacterial plus viral pneumonia. I don't know. He's a little tenuous, so he'll be full code. We're just gonna have to keep a close eye on him. That's the gist of it. You did it in a couple of minutes. You've given him the highlights. You've given him you peppered in some of the little minor things that you're just going to watch but not do much about. And that's all they need to know. You don't need to give them every single detail, especially if you're already established with them. I think this is actually a good presentation even if you are fairly new. You're concise, you honed in on your pertinence, they know the things to look out for, they get a general feel for how sick this person is. So then I would go and write my note. The whole point of this is to speak with your attending and to make sure that you have the right diagnosis and that you're on the right track, that you're ordering the right things. I mean, what if none of this is true? What if this dude has interstitial lung disease and you're totally off the mark? This is not something to be intimidated by. I know it's an intimidating process, particularly when you're new. It will get significantly easier with time and experience, and once you just get a general sense of what you need to do and competence in your skill set. But don't let it scare you to death, okay? Take a deep breath, use your smart words, and realize that sometimes even when you're years into this, your smart words don't come out. And you look like a big dummy, or you're completely off the mark, or you just didn't say what they wanted you to say. Let's be honest. Many of these people have their own experience and background and biases, and that's what they see, regardless of what you see. So it doesn't necessarily mean you're wrong. We're all working together to get the right treatment for the patient. So it's going to be just fine, and you're going to get better and better and better at this, okay?